Anybody have the lab manual?
Yeah, we're going to do lab 28 because we are going to dissect the heart. So we're going to do just a little bit more lecture, and then we're going to do that. Okay, so after we've gotten to this point now, where the blood has filled the ventricles, we know that sound 1 is those atrioventricular valves closing. The ventricles are they're trying to contract, but at this point, all valves are closed, and then we begin to get the ejection of the blood, and sound 2 is going to be that semilunar valve opening. Now, the semilunar valves are going to be either the pulmonary or the aortic, okay? So they're going to open, and the first thing that's going to happen, because there was a huge, good amount of blood coming into the ventricle, that blood amount has got to go whoosh. Now, we know that there is more cardiac muscle on the left side than the right? So when we look at the structure of the heart, the left is full of the cardiac muscle, right? The right, only a little bit, okay? Because where did the right have to pump it to? This one only has to go to the lungs. Doesn't have to go very far, okay? I ain't even gonna try to draw the pulmonary trunk, okay? Because, I mean, that's just, if I was an artist, yeah, but I'm not. So, it has to go only a small distance into lung tissue. But over here, we've got this huge amount of muscle that's going to go through the depolarization, meaning we're going to reach threshold. If we reach threshold, it's going to contract, all right? And that's a huge amount of muscle to be pushing that blood out. So semilunar valves open, and we get that huge rush of blood into this aorta and into the pulmonary trunk. Which one do you think you're really hearing? Our aorta, okay? Because those semilunar valves, all right, they're going to be pushed open. The first thing that's going to happen, we get a huge ejection. So that's termed the rapid ejection of the blood. And then the slower flow is the reduced. The ejection lasts about 200 to 250 milliseconds, corresponds to the plateau. Remember the little thing we drew? The T wave starts at the later part of this phase. Now, what we are going to find is something called stroke volume. Now, see how we've got this end diastolic volume, stroke volume, end systolic volume, all of it being volumes. This is the normal amount of blood that should be in the heart at a particular time. So if it is end systolic, there is a number that should be the normal amount of fluid in that ventricle at the end of systole. End diastolic, means there's a normal amount of blood that should be in there at the end of diastole. And then stroke volume. Stroke volume, we're getting about 70 milliliters ejected out. Now, does that sound like a lot? For something about that big? Believe it or not, there's even more in there. That's what's ejected out. Now, this would be the norm, okay? Like, for example, as you're sitting here right now waiting to dissect that heart, so I'll quit talking, okay? That's about the norm of what should be moving out. But that's not what's in the actual parts of the heart. What happens if you were to start some kind of physical activity? That's going to increase. We're going to learn about that in the next chapter. It's really cool, okay? We get about 60 milliliters left over that stays behind. Now, that blood that stays behind, is it going to just sit there and be stagnant blood? No, because we have the constant motion, the constant mixing. So, it's just anybody's guess which part's going to go out. Okay, so it's really kind of cool. So then, when we have relaxation, all right, isovolumetric, referring to the amount, T wave is ending, ventricles begin to relax, blood from the aorta and the pulmonary trunk, they briefly flow backwards, but we do not want that backward flow to be to the point that blood does this number. We only want backward flow enough to close the valves, semilunars. So hopefully that will close the valves, begin to create the pressure, and we're hearing heart sound too. Because once again, as it opens, pushes out, gets that movement of that valve, once again, turbulence in the blood. And anything that causes turbulence in the blood is making it move against all the tissues, and that's what we hear. So, we've got this sound, okay, isovolumetric, because semilunars, the aorta, the pulmonary, they're closed, but the atrioventricular, the tri and the bi, haven't opened yet. And we therefore have turbulence in these tissues. When the AV valves open, the whole thing starts all over again. That would be our one cardiac cycle. So, remember about 1 second? And a person who's at rest, atrial contraction, about 0.1 seconds. Ventricular contraction, about 0.3. When all the 4 chambers are in relaxation, about 0.4 seconds. Because what are we needing to occur? We need those cardiac cells to go back to their resting membrane potential. We cannot have them stay away from that. So, the total duration of a cardiac cycle is roughly 0.8 seconds. I don't even know how long that is. But if you put it into a minute, it comes out to roughly 75 beats per minute at rest. That will change if you go out of rest. So now, these are our 4 events that should be occurring in this cardiac cycle. If they are taking place at the correct time, there will be certain events occurring in the ventricles of the heart. There will be certain sounds that would be heard on auscultation, and there would be something that matches or correlates to the EKG and be able to determine which is in relaxation, which is in contraction. Isn't that kind of cool? 75 beats per minute. So what do we know about these volume changes? At the end of contraction, there's roughly 60 milliliters of blood in the ventricles. During the atrial relaxation, you get about 30 milliliters. Added by the atrial contraction, about 40 milliliters. So, at the point when we look at the full volume in the ventricles, roughly 130 milliliters. When we are looking at ventricles and the ejection of the blood that needs to take place. The stroke volume, what gets ejected when those ventricles contract, roughly 70 milliliters gets ejected out. 70 from 130 is 60 milliliters, which is what we started with. The goal is hopefully all these volumes stay the same, that the ejection that will occur left and right, the filling that will occur left and right, that will stay the same. Does that always happen? No. But that's definitely something wrong with the heart. So, under normal conditions, the same volume of blood, even though different pressures are present, is getting ejected. When someone is in congestive heart failure, ever heard that? CHF? Mm-hmm. When someone's in congestive heart failure, one of those ventricles, okay, is not ejecting blood effectively, either the left or the right. Usually, it's a result of a myocardial infarction, a heart attack. It could be the person who's under chronic hypertension. Good, how are you? Chronic hypertension. Ever known somebody under chronic hypertension? It's like no matter what they do, no matter how many medications they take, it's almost impossible to get their blood pressure under control. Well, after many years of that, it begins to take a toll on the heart. And usually, congestive heart failure can be the result. It could be someone whose valves are not working correctly, or congenital defects in the heart structure, which a lot can be, surgically corrected now, but it just depends on what the defect might be. We can also see that the left ventricle, when the left ventricle fails, something else that happens, blood backs into the lungs, and it causes pulmonary edema. Ever heard of that one? Yeah. It's like a drowning of that lung tissue in your own fluids. Yeah. Usually, people begin to feel like they are suffocating, shortness of breath, and they have to take certain measures to take care of that. When the right ventricle fails, blood backs up into the vena cava because the superior and the inferior vena cava feed into that right atria. So if the blood backs up into those vena cava, that means it's not getting good flow from all systems of the body, the tissues. So what is that going to do? It's going to cause either something in the system to become edematous or a generalized edema, a swelling all over the body. This could be due to enlargement of the liver, someone who has liver disease. Are y'all familiar with this one? Ascites? What is it? That's what the definition is saying. What does it look like for a person? The stomach is very enlarged and hard, and I mean, it's like rock hard. Yes. And then people who are malnourished, okay, they'll have that, and that's the fluid building up there, and it's termed ascites. You can have distension of the jugular veins, and then if it's like generalized, it could just be pretty much swelling of the body all over. I mean, we get like, you know, someone who may sit all day long at their job, okay? What can usually happen as we get older to the lower legs? Fluid pools. We get the swelling of the feet and the ankles and the calves and that sort of thing. But this could just be something that's all over. What'll happen, any of this can eventually lead to total heart failure. And that, of course, is going to lead to death. So this is going to be what would happen if we get the left ventricle not functioning properly. We'll get the backup into the lungs and the fluid buildup there, being the pulmonary edema. If we get the backup from the right side can be systemic or just the generalized overall edema. So it's really interesting what can happen. All right, so for lab today,